Hey everybody! Okay, this is going to be a short video, and I'm going to try to make it even shorter than the previous one, because I been thinking that, with my pizza philosophy, yeah, you do have a text, so if you want more of a thorough, and I promote that, you should have a text resource. Remember, that's one of the top 3 ingredients of your pizza. You should be taking a deeper dive, and that's where generally you take it. And perhaps also, if you're going through a face-to-face course or an online course, maybe your teacher has either recorded presentations, or maybe you have face-to-face instruction, that sort of thing. So these type of videos, I want to be more of an overview, okay? Now, another thing, like I was saying before, try to draw stuff out, okay? So I've got another visual for you guys. Now, today's topic is anxiety. Anxiety. And I know a lot about anxiety because I deal with anxiety. I've had anxiety for quite some time. I've probably had it since I was a kid and probably just didn't even know that's what it was. And that's something to think about when it comes to mental health and diagnoses across the lifespan. And one thing that in most mental health courses, I know we cover it, or I cover it in my courses, is changes across the lifespan and different diagnoses specific to mental health. But also, you're going through your nursing program. I'm sure you'll have pediatric or either a combined maternal, newborn, / pediatric or families type course, something like that, where you'll look at physiological diagnoses within children, the geriatric population, that sort of thing. Adolescents, remember those great old teen years, okay? When our parents knew nothing, all right? We knew everything. We all go through that. Well, in mental health, you can also have, diagnoses across the lifespan. So that is one thing to consider is with your younger population, depending upon how young the child is, they may not be able to communicate to you, number one, if they don't have communication skills at that given time, things that's going on, thoughts that they're having, or, feelings inside, that sort of thing. The other part of that is they may not attribute and the word that's come to mind is like an abnormal sense to those feelings. They may just think that everybody, feels wound up tight most of the time, okay? It was up until you guys, I was like 30 years old before I had one of my buddies at night say, basically, you have anxiety, which I knew I had anxiety, but I was kind of probably denial, a little bit of an ego defense mechanism there, and hadn't really sought treatment. I was, one of these people. I've always been a mental health advocate, but I just think, I can do this. I'm stronger than this. I can overcome it. Well, there's strength in asking for help, okay? So, anxiety. So, here is a visual, and again, you sketch your own visual out. You draw out your own concept map, okay? So, don't laugh at my art skills. Here we go. I'm going to give y'all a second to kind of look over it. Okay. This is a self-portrait here. This is Dr. Jake having anxiety, okay, over frogs. I can't stand these frogs, all right? I've got a frog right now in my backyard. I done picked the guy out of the pool once, and he got back in the pool. Every time I open the skinner, about jump out of my skin, okay? And I had a good friend of mine say, well, call your neighbor. No, I'm not calling my neighbor. They're going to laugh at me because they're going to say, you're scared of this little bitty frog. Well, actually, he is not a little bitty frog. He's about that big, you guys. He's not a big toad, but I don't know what he's eating, but he's eating some meat and potatoes or something, okay? And I really about came out of my skin when I thought the other day he was gone, and there I was, just swimming, okay? Just floating, having a good old vibing time. And then I look over next to me, and he's... I found the Lord that day and got out of that pool, okay? I was walking on water, all right? So, to illustrate this particular concept, that's where I've got anxiety, okay? These are thoughts, you guys. Sometimes there's a word that's called, well, not sometimes there's a word, but ruminate. Sometimes we have obsessive thoughts and we think about something over and over and over again. Look up rumination. I bet you that's one of your keywords in your text. Okay? Now, as far as A and I, here's your ADPI. Remember, I focus on assessment and interventions. That's generally where you see most of your questions, okay? Prioritize your interventions per, and this is my little triangle here for Maslow's hierarchy of needs. I feel like if you're in a mental health course, you're probably at this point familiar with Maslow's hierarchy of needs, but if some reason you're not, it's in most text, okay? So you're prioritizing. Remember, your physiological needs are on the bottom. Just because you're taking mental health does not mean you throw acute physiological needs out the window, okay? But in our assessment, when you look at most texts, and some of your nursing test questions come from these 4 levels of anxiety. Now, I've color-coded these. Look how I drew out my anxiety. And also, look at the directional arrows. Look. Notice the arrows kind of narrow as you get towards the end of anxiety. Notice at the beginning, it's yellow. And that is because yellow signifies mild. Mild anxiety, that typical level, is motivating. So think mild, motivating. Yellow, we're still doing okay. We may feel at this point, whatever text you're reading, you may feel a little apprehensive, you may feel a little irritable, you may feel a little restless, but generally it's motivating. It's like you've got a test coming up, the end of the week, you have a little bit of mild anxiety, you're going to study for it, okay? But then you move on to moderate. Now notice that moderate goes from yellow towards orange. So that's where you kick up a little bit. You may have a little bit of muscle tension. You're going to keep that apprehension and such. You're just adding to it, okay? And then you get to severe. Notice that severe goes from orange to red. So increased physiological symptoms, okay? And then you get to panic. Notice the exclamation point here, and it's red. So notice it corresponds to a little bit of the E, the T, and the Y. Now, if you're at a panic level, just similar to if someone has an underlying panic disorder, you need to think of safety. And I'm getting a little ahead of myself, but remember, safety is your priority, okay? So when we're assessing anxiety, typically some of your questions will come from, say, what particular level. Now, generally, they're not getting at, can you memorize from mild to moderate? But look in your text. Look at the progression from mild to moderate, okay? Another thing about assessing anxiety, okay? And I'm going to struggle here a little bit because I'm on my glasses. But I'm looking at my 3x5 cards. Again, kinesthetic. You should be making your own little Cliff Notes version. Helps you process the information. But think of fight or flight. Think of that sympathetic response. Think about the upkick of epinephrine, norepinephrine, right? One way I help to kind of remember what happens in the body. Well, I didn't come up with this. One of my prior nursing mentors back in the day, I remember this person saying this to me, saying, you got to see to run. So your pupils dilate. Your bronchioles dilate, like, because you got to have that air exchange to get in and out, to get away from that frog, okay? And, of course, you're going to see things like tachypnea, tachycardia, increased sweating, all right? So think of that fight or flight response. Now, again, that is a survival thing. If you think back, and usually in some text, sometimes they put a funny-looking tiger in there or something like that, that the caveman was running from. So that was a survival. That is our embedded survival response. But if you look at the nature of chronic anxiety in the body, and if someone, chronic anxiety, chronic stress. So that is a stress response. And I apologize. Now I can't remember if I misspoke just a second ago. But I'm talking about the stress response. Because if you think about stress / anxiety, typically those two kind of correlate as far as physiologically in the body, what is happening. Okay, we have that sympathetic response. But the other thing that you'll read about in most text resources is the chronic nature of stress and the ill health effects. You know, we know it increases the stress hormone of cortisol, and we know over time it increases risk for cardiovascular events and hypertension. You know, increases hypertension, especially, well, technically, like, you know, if you're fairly young or maybe you don't have underlying hypertension, the stress response, will increase your blood pressure, but usually, you know, you maybe either the stress stimulus goes away, the frog swims away, and you catch your breath, or whatever, you know, is stressing that person. And then they're able to go back to homeostasis, where the body's in a little bit more engaged with that parasympathetic system, okay? So, look at, I'm just trying to make sure mentally, am I covering everything that I want to with assessment? How does this person present? Now, as far as you guys, standardized assessment tools, sometimes you will see test questions related to, is there a standardized assessment tool? So look in your nursing text and see which one they provide to you. One that I wrote down, I can't find where I wrote it down, but I know it's the Hamilton Anxiety Rating Scale. Okay. Oh, risk factors. Here we go again with females tend to have more anxiety. All right. More occurrence of anxiety. But of course, we know there's a genetic component as far as if someone's predispositioned, if you have generalized anxiety, maybe a history of that in your family. Okay. Also, don't forget, excuse me, potentially medical reasons that someone might have underlying anxiety. Can you think of any? What about a pulmonary embolism? What about hyperthyroid? So those are some things to think about, okay? Oh, and what about a substance use, like the particular substance, or maybe a withdrawal from substance, okay? That could be that person feeling anxiety. Excuse me. Now, what else I want to say about this? As far as diagnoses, again, you don't see a lot of test questions related to particular diagnosis, but just to kind of get you in the mind of anxiety, I've already named one, generalized anxiety disorder. This is where you see your phobias. And I said I was going to remember because I actually looked this up. I think a fear of frogs was like something randophobia or something like that. I'd never heard of it before. Okay. Social anxiety disorder. I do have a little bit of that as well. Panic disorder, we already talked about that. So all those particular disorders correlate to where you see underlying anxiety, or they have anxiety components. Maybe that's a better way to say that. Now, treatment. So remember, a lot of your questions, generally most of your questions, come from assessing. That's the A here. And then look at my eye. Look right above my eye. I can hardly see it without my glasses. But notice I put a do. What are we going to do about this? So notice the first thing I have there is just like the depression. Safety first. Okay? If this person, you guys, is at the moderate, like if they're getting to where my moderate, remember how I turned my moderate, the first part I put in yellow and then it went to orange. So that person is having increasing levels of anxiety and they're going from moderate to severe to panic. The higher levels, the more they start to progress, you better think about remaining with this person, okay? For safety. Safety first. So when you think about interventions and you're reading in your text, look at that. A lot of times they will stamp that out pretty clearly, that someone in advanced stages or advanced stages, kind of, put you in the same vein there. But you need to remain with this person, and you don't want to falsely, when you think about, yes, you want to use therapeutic communication, but say that they're having anxiety because we live in Florida and it's hurricane season, that a hurricane come through and wiped out their house. This is, of course, you wouldn't want to provide this person with false reassurance that everything's going to be okay. Your insurance company is going to cover your house 100%, okay? So do not use false reassurance. But ensuring, say if you're inpatient with this person, maybe they're in an inpatient mental health unit or psychiatric unit, ensuring that they're in a safe space where you are, okay? Other no, hold on, before I get ahead of myself. Another thing, you might want to consider to assess suicidal and homicidal ideation or risk, okay? That goes along with the safety. You know what? One thing I didn't say about that panic and the arrows that I had going down. You're getting into that panic phase. Think like panic paralysis. Like a lot of people, once they get to the panic level, they have lost all rational thought. They cannot compute, okay? They cannot focus. They are, a lot of times what I mean is like paralyzed by the anxiety, paralyzed by that high level, that panic level, okay? Now, beyond safety, and and think of the safety of your milieu too. Milieu is your environment. You want to try to promote a therapeutic milieu. So you need to ensure the safety of other patients that are on the unit. Safety of yourself, safety of the patient in question that is going through this anxiety. Now, from there in your brain, I want you to branch to non-pharmacological to pharmacological interventions. So if you're drawing out a concept map, put anxiety in the middle and branch off from there. What would you do to assess it? What does this person look like? How do they present? Okay, and then think again, we already talked about the sympathetic nervous system response, okay? Now, non-pharmacological, one of the things I put down here was CBT, Cognitive Behavioral Therapy. And this is like a combination of cognitive therapy and behavioral therapy. And what I mean by this is cognitive, looking at possibly thought reframing, especially if someone is having negative self-talk. If they are looking at, say, a particular stimulus, stressful stimulus, and again, I have personal experience with this. Automatically, my brain, if it's a stressful stimulus, will start thinking, sometimes start spiraling, thinking, well, this is going to happen and that's going to happen. Usually it's all negative, negative, negative. Or if it's something, it doesn't have to be something physically that's happening in front of you. It could be something even internal. And it doesn't have to be negative necessarily. Maybe you're going up for a job interview and you're nervous about the job interview. And then you start thinking, well, you know, what if I perform poorly? What if I don't answer the questions correctly? You know, and you need a good friend. Social support is one of the key adaptive coping mechanisms, or we'll say positive elements. It's not really a coping mechanism, but one of the key elements, a good social support network that can help people navigate this continuum of mental health versus mental illness, okay? So a counselor can do this as well and help you reframe those thoughts to think, well, now you're jumping ahead of yourself. Nothing has even happened yet. So how can we reframe those thoughts, okay? So that's kind of like the cognitive. Now, the cognitive, the B comes in because oftentimes, our thoughts, once we start spiraling, will inform and, of course, influence our next behaviors. So we want to make sure that we want to really look at what kind of thoughts we're having, and do those lead maybe to self-harm behaviors or either maladaptive type coping mechanisms, okay, such as turn into substances, okay? All right. And then I put under there as well, therapeutic communication. And we kind of already touched on that. I'm not going to cover communication in this video because you're going to read about it. Now, I will probably make a separate video to kind of stamp out therapeutic versus non-therapeutic or barriers to therapeutic communication. Okay. What else did I want to say about that as far as non-pharmacological? Your environment. I want to go back and say a couple things about that environment. How about a calm environment? How about a potentially decreased stimulating environment? So something, say if they're inpatient and the unit's quite busy, is there a space? Maybe they request to go into the seclusion room or, what have you. And that's not considered seclusion if the patient is requesting to go in there to kind of take a time out, to collect their thoughts. And it depends on the unit, of course, whether they have private or, say, son of a gun. Like where you have a roommate, okay? This is my social anxiety, you guys, okay? Like double bunked. Y'all get what I'm saying. What else? They will do well with a structured environment. I've already said remain with the client. I've already said assess the suicide. Now, other things as far as safety, close monitoring. You might see that one-to-one. Typically, you see that more so often, though, with like the increased suicide risk. So if they were having suicidal thoughts related to the anxiety or whatever type of crisis is happening in their life, then you may see a one-to-one. Now, other non-pharmacological things that you could teach your patient having anxiety is some form of relaxation techniques. One thing we were talking about just the other day in one of my classes was naming 5 things. And if you're not, 5 things. If you're not sure what this is, typically it's what you see. You can Google it. You can look it up on YouTube. Is name 5 things. And I don't, there's not really a wrong or right to this. It correlates with your senses is what I'm getting at. Now, I was actually practicing this the other day when I was outside, and I found it beneficial. Try it and see what you think. I closed my eyes first, and then I tried to name 5 things I could hear, okay? And it really helps you focus. It really helps you center in and kind of slow down those thought processes and be in the moment. So if you're having those spiraling out of control, ruminating thoughts, and again, you can teach your patients this. This is a great intervention. 5 things I can hear, okay? Then what about 4 things I can touch or feel? And then what about 3 things you can smell? You don't have to keep your eyes closed, okay? I was just closing my eyes. 3 things you can smell, 2 things you can see, and 1 thing you can taste. And it doesn't have to be in that order. The purpose is it kind of grounds you into the moment. Because again, sometimes we start spiraling out of control when we have anxiety. All right. Some other, now specific to behavioral therapies that you might read in your text is things like modeling. M-O-D, I got that southern twang, but M-O-D-E-L-I-N-G, like where someone models, and hopefully you as a nurse model for that person some good behaviors or some good adapting coping mechanisms. Another type of behavioral therapy you might read about is systematic desensitization. Now, generally, the way this kind of goes down is you have someone maybe imagine a little bit of something. So if I imagine a little bitty baby frog, just a little bitty tadpole, that's all it is. And then if at that point, though, my anxiety starts to kick up, then I immediately start to use maybe some deep breathing or some other form, or do the 5 senses trick, okay? And then you progress, okay, with the idea with systematic desensitization. Desensitization, think about that word. That's kind of cluing you into what this is. And systematic. So progressively, you up the ante. Maybe the frog gets bigger, okay? or maybe it gets closer to you. And then again, you utilize those adapting coping mechanisms, whether it be breathing or the five senses, that sort of thing. All right, now let's see here. Another one you might read about is, I'm not a fan of this, but flooding. Now, flooding, my friends, would be, when you employ flooding, it's like immediate exposure to that particular stimulus that causes anxiety. When I looked over and saw that frog next to me and about came up out of my skin, and I could not get fast enough out of that pool. But if someone was using flooding, usually it's kind of along those lines, like immediate immersion, if you will, into that particular stimulus that causes anxiety. Like particularly, sometimes you see that with phobias. Okay, now let's talk about the pharmacological interventions. This is going to be an overview, okay? The cool thing about this particular class of medications, your anxiolytics, is this is one of the few endings when we think about benzodiazepines. Benzodiazepines. Sometimes you'll see it when people are talking about it. Maybe nursing students are studying, or, you may hear benzos. Well, if you hear that the same sentence with anxiety, you're ding, ding, ding. You're thinking benzodiazepines. Now, benzodiazepines end in lambs and pams. Typically, like a little cartoon you might see is Call Pam to help you remember. And that's your benzos. Now, benzos are great, okay? But they're also addictive. Someone you can potentially become dependent upon benzodiazepines, and you can develop tolerance. So they're really intended for acute management of anxiety. Okay, but other than that, and you also have to think about your potential side effects, which of course will be drowsiness and dizziness. Okay. So CNS, effects, is what we're getting at. Okay. What else? Your SSRIs, selective serotonin reuptake inhibitors. A couple of these are sertraline and paroxetine. Okay. And your serotonin norepinephrine reuptake inhibitors, venlafaxine, and duloxetine. All right, those are two SNRIs. Now, an anxiolytic that is not a benzo and does not fall in an SSRI or SNR class that is FDA approved for long-term treatment is buspirone. Okay? So, that is an overview of your medications. Now, I've already said that in my depression video. Listen to my other video about antidepressants. And, these are SSRIs, SNRIs fall under that antidepressant category, but they can also be used, or some of them, not all of them, okay? I named 4 right here that I know can be used for anxiety as well. So they would have, the same side effect profile as they would if you study the side effect profile as you have for your antidepressants, okay? All right, what else did I want to say about this? Remember the onset, I will say this, for like your typical SSRIs, SNRIs is 4 to 6 weeks. Buspirone, I did write a note for myself, onset is 3 to 6 weeks. And you don't have the potential for dependency or tolerance or withdrawal that you do as the benzos. Usually your test questions specific to anxiety, and I've already mentioned a couple of these, are related to the levels. perhaps a standardized assessment scale. I see a lot of therapeutic communication questions that tie back to how would the nurse reply in a therapeutic way and that's across all mental health diagnoses, okay? And then specific to benzodiazepines, call Pam, so think Lamb and Pam. And usually you may see a couple questions related to the dependent nature of those medications and the tolerance that builds up. And you can have withdrawals from benzodiazepines, okay? So, I think that's all I wanted to say, you guys. Let me look at my picture here. All right. I didn't do well at cutting down on this video. So, thank you for tuning in. See you guys next time.